A patient presents with long-standing headache, galactorrhoea, and hypercalcaemia. Following an abnormal pituitary MRI, the patient underwent a Gallium-68 Dotatate PET-CT. Describe the findings.
Okay. The selected Gallium-68 Dotatate PET-CT fusion images show intense focal radionuclide tracer uptake at 3 distinct anatomical locations. The first focus of intense tracer activity is localized within the pituitary fossa, corresponding to the clinical history of Galactorrhoea. The second focus of hypermetabolic uptake is noted behind the left lobe of the thyroid gland, consistent with a parathyroid lesion explaining the hypercalcaemia. The third focus demonstrates high tracer avidity in the tail of the pancreas, indicative of a primary pancreatic neuroendocrine tumor. The combination of these multifocal neuroendocrine lesions in a young patient is diagnostic of a syndromic process.
What is the diagnosis, and explain the differential diagnosis for this presentation?
The diagnosis is Multiple Endocrine Neoplasia Type 1, which classically presents with a pituitary prolactinoma, parathyroid hyperplasia or adenoma, and a pancreatic islet cell tumor. The primary differential diagnosis is Multiple Endocrine Neoplasia Type 2, specifically subtype 2A. While Multiple Endocrine Neoplasia Type 2A also presents with parathyroid hyperplasia, it is characterized by medullary thyroid carcinoma and adrenal pheochromocytomas. It is not associated with pituitary macroadenomas or pancreatic neuroendocrine tumors, which helps differentiate the two syndromes.
Explain the genetics, typical presentations, and classic acronyms used to remember the features of MEN1, MEN2A, and MEN2B.
All multiple endocrine neoplasia syndromes are autosomal dominant conditions with high penetrance, requiring genetic testing of first-degree relatives. The manifestations of multiple endocrine neoplasia type 1 can be remembered by the acronym PPG, which stands for parathyroid hyperplasia, pituitary adenoma, and gastrinoma or islet cell tumor. Multiple endocrine neoplasia type 2A features can be remembered using the acronym PPM, representing parathyroid hyperplasia, pheochromocytoma, and medullary thyroid cancer. Multiple endocrine neoplasia type 2B features are summarized as PMM, standing for pheochromocytoma, medullary thyroid cancer, and marfanoid habitus, with mucosal neuromas. Carney complex should also be considered, which presents with cardiac myxomas, skin pigmentation, and Sertoli cell tumors, but is genetically distinct.
Describe the role of Gallium-68 Dotatate PET-CT in imaging these syndromes.
In that case, Gallium-68 Dotatate is a somatostatin receptor agonist that binds specifically to somatostatin receptor subtype 2. Because neuroendocrine tumors highly overexpress these receptors, Dotatate PET-CT offers exceptional sensitivity for detecting primary and metastatic lesions. In syndromic patients, like those with MEN1, a whole-body study is critical for staging and identifying subclinical lesions throughout the body. It is superior to standard CT or MRI for identifying small pancreatic islet cell tumors and parathyroid adenomas.
Discuss the appropriate further management, genetic workup, and how you would manage this patient as a radiologist.
Well, management of MEN1 requires a multidisciplinary approach to address each component of the syndrome individually. The pituitary prolactinoma is typically treated with dopamine agonists, while the parathyroid hyperplasia requires subtotal parathyroidectomy. The pancreatic neuroendocrine tumor may require surgical resection depending on its size, functional status, and metastatic potential. As a radiologist, I would recommend immediate genetic counseling and testing for the MEN1 gene mutation for both the patient and their first-degree relatives.